Good afternoon and welcome to today's webinar. Thank you for joining us. My name is Emily Haines. I'm the Director of Public Health Initiatives at the Partnership for Maternal and Child Health of Northern New Jersey, which is hosting today's program. Our webinar today is titled Pediatric COVID Vaccine, Talk with the Experts. I would like to review some information before we get started. The planners and speakers do not have any financial disclosures to make. Immediately after the webinar ends, as well as in an email, you will be invited to take a post-program evaluation. We appreciate your feedback, so please complete the survey. In order to receive a certificate of completion, including 1 nursing contact hour, you must log in, listen to the entire webinar, and complete the evaluation survey. Certificates of completion will be sent via email within 1 week of the webinar broadcast. This program is being recorded and will be available on the partnership's website and YouTube channel no later than November 9th, 2023. We will be muting all attendees' microphones during the presentation, but we would love to hear from you. Please write questions in the question box and the speaker will respond to as many as possible at the conclusion of the presentation. Now I would like to introduce today's speakers. Dr. Katharine Clouser, who is joining us via audio today while we are working out her webcam, is an assistant professor of pediatrics at Hackensack Meridian School of Medicine. She is board certified in pediatrics and pediatric hospital medicine and has published extensive peer-reviewed work throughout the pandemic on COVID-19 in the pediatric population, including outcomes in children and adolescents with multisystem inflammatory syndrome in children, otherwise known as MIS-C. She is the medical director of Hackensack University Medical Center's COVID Recovery Center. Dr. Jeffrey M. Bienstock is a board-certified pediatrician and has worked to improve the health of children in New Jersey and abroad for the past 25 years. He has been honored by the New Jersey chapter of American Academy of Pediatrics as Pediatrician of the Year and has received the Childhood Immunization Award from the CDC. He is currently a pediatrician at PediatriCare Associates in Northern New Jersey. Welcome, Dr. Clouser and Dr. Bienstock. Thank you so much for joining us today.
Thank you.
Thank you for having us.
Okay, so let's get started with our discussion. I have some questions for us to talk about, and then we'll open it up for questions from the audience. So Dr. Clouser, can you please tell us how is COVID-19 spread among children and how does infectivity of COVID-19 in children compare to adults?
So that's a great question. And one challenge that we've had throughout the pandemic is that we don't have a great idea of at baseline what the infectivity is. We use a value that we call R prime. You might see it in the news or in studies or different things like that, that actually talks about how many people one person who's infected can spread. So in children and adults, one of the challenges that we had is right back in March of 2020, we stopped everything. So there's no baseline data on exactly how infective this is. We're all still wearing masks. We're all still kind of staying home when we're sick, which is all positive things. What we do know is that there does not seem to be the same spread of children to adults as there is in adults to children. So it does appear that children to adults is not the core spread. And in all of our school outbreaks that we've had and the looks there, it's not usually the children to the teacher, it's the teacher or somebody else to the children, or maybe a parent at home to a child. Children can spread to each other, but again, it's not seeming to be as infective as it was in adults in the beginning of the pandemic. It is spread via droplets, which means sneezing or coughing nearby somebody else. It's difficult to spread simply by breathing for a short period of time. So if you're just passing by somebody in the grocery store, it's unlikely that you'll get it. But if you're with somebody for an extended period of time, maybe for 15 minutes, that's the number that we're looking at. And children will spread it to each other via coughing, sneezing, talking, kissing, singing with each other, those kinds of things. So it is spread that way. What we do know is that it is not spread via contact, which means touching or touching a surface as much as we thought it was. So I know back in, March and April of 2020, lots of people were cleaning their groceries, opening up packages outside, bringing them inside. That is not the way that it is spread. If somebody has COVID and touches the desk and you touch it 10 minutes later, you're probably not going to get it that way. But it is still really important to wash your hands and to wear those masks. So from what we can tell, children are not as infective as adults are, and adults tend to pass to children, but maybe not children to adults as much. Children to children can pass, and again, it's through coughing, droplets, and speaking kind of in close contact with each other.
Thank you, Dr. Clouser. So as a follow-up, how does it compare to another vaccine preventable disease, let's say measles?
Good question. So measles is very infective, and measles has what we call that R prime level of about 1 to 15. So one person with measles can infect 15 other people. And I have to tell everyone who can't see me on video, I'm gesturing and making numbers, forgetting that I'm not on video. So I am a real person. But I think that with the COVID vaccine at our height, we were seeing about 1 to 3, 1 to 5. The R prime number that we have in New Jersey currently is less than 1 to 1. So one person is infecting less than one person with COVID. And that number does change, and it's something that you can find on the Department of Health website, and it's also something that the news will sometimes report of what our infectivity level is. Like I said, in March and April of last year, it was probably 1 to 3 to 5. So it's about, a third as infective in the height of the pandemic. And now it is much less infective than measles was.
Okay. Thank you. So Dr. Bienstock, how concerned does a parent of a young child need to be about COVID-19 infection in their child?
I think everybody needs to be concerned, whether they're elderly or they have a newborn child. Our understanding of COVID-19 is still a little bit in its infancy. Here we've been dealing with a pandemic since March 13th, which was Friday the 13th when it seemed to hit, but we know there may have been some cases even before that. And I think for the average parent with a child that's school aged, there's a lot of things that we need to be worried about and concerned about. One of the things is keeping them in school. Obviously, a child that's sick needs to be quarantined until their test results are back. So the infection is only part of what we're worried about. This lack of socialization for children 2, 3, 4 years old that need to be in daycare, that need to be with their peers, that need to learn from each other. I think this has blunted their social skills. And as a parent of a 30-year-old, a 35-year-old, a 38-year-old, as a grandfather of a 13-month-old and a 22-month-old, we need to be worried. Statistics have shown that these children are not as sick as elderly people or people with underlying medical conditions. While we've seen a rise over the last 2 months in the pediatric population of illness and infection, we're not seeing the number of deaths, nor have we ever. And depending on where you look, the number ranges anywhere from about 600 to 800. More than we would typically see in the influenza season, which is knocking at our door right now. But I think for any parent to say this is not real or, don't worry about it, I think they're short-sighted, because even a child could spread it to a parent or a grandparent. And with the holidays coming upon us, with Thanksgiving 2 weeks away, I think we need to be concerned to try and get as many people vaccinated and have as many people protected as we move into what should be a joyous time for many families.
Thank you, Dr. Bienstock. Vaccination is definitely the way to get back to normalcy. And like you said, for children, that sense of normalcy and attending school and social activities as part of their healthy childhood development. So vaccination is really important for that. Dr. Clouser, looking at some of the long-term effects of COVID-19, one of the areas of concern that we have for children being infected with this disease is MIS-C. Can you please explain more about that and how it impacts children and what we've learned about this inflammatory illness from COVID-19?
Absolutely. Last April, so April of 2020, there was some reports out of the UK that were saying that they had this kind of inflammatory illness. And what that means is that the body is overreacting to some sort of an insult. And we have other illnesses that are similar to this. There's something called Kawasaki disease, which is very similar in presentation and can cause a couple different symptoms. You can have abdominal pain, you can have difficulty concentrating, some mental status changes, as well as rash, changes in the mouth where the lips are very red or the tongue is very red. And in the United States, we really kind of started to notice it at the end of April. And in March 15th, actually, of 2020, the CDC came out with its own definition. And what it is, it's called multisystem inflammatory syndrome in children. And it's kids who are about 4 to 6 weeks post their initial COVID infection get this hyperinflammatory symptoms where they're having more than one system involved. So when we talk about medical systems, we're talking about the brain or the GI tract or the skin or their lungs. And if they have more than one of those involved, plus some evidence of inflammation, and the real evidence that parents see of inflammation is fever. And then we do some lab tests that help with that. In the state of New Jersey, we've had about 150 cases. I think it's a little bit more than that, but about 150 cases of this that has presented. It may be up to 200 now as I'm saying this out loud, it's 200 now, where kids 4 to 6 weeks after infection have had this. Sometimes people knew that they were infected and sometimes they didn't have symptoms. And it's presenting with some pretty severe symptoms. The worst part of MIS-C is actually the cardiac events. So actually within the heart can be a little bit weaker than it was prior to this syndrome, and it can cause problems pumping blood. We do know how to treat it, and children are doing exquisitely well. So the kind of key concept with MIS-C is to get it treated early. Within New Jersey, we've had 1 death of a child from MIS-C, and 1 is too many, but we've done a really good job with management because our community pediatricians have been sending these kids in early to get early treatment. So if your child had COVID or you didn't know if they had COVID and they've had fever for a day or so and are just seeming not to be themselves, it's really important to talk to your pediatrician because this can be a sign of this kind of infection. So the inflammation kind of takes over their body, attacks their organs. We treat it with steroids and we treat it with a medication called IV immunoglobulin. It helps to calm down the inflammation in the blood and kind of reverses the process. I also see kids in follow-up, and I do like to say that the good news is most kids do really, really well, and I've been following about 40 kids in the last year, and I have some who are more than a year out from their MIS-C, who were in the ICU needing really critical care, and they're all doing very well back to school. So if we treat early, we can fix the inflammation, and they all do very well.
Thank you. That's good news. Dr. Bienstock, let's stay with the cardiac impacts of COVID-19 and talk about what's been in the news over the last few months about the rare side effect of myocarditis from COVID-19 vaccination in adults and adolescents, and also the association of myocarditis with COVID-19 actual infection. Can you talk about that relationship and how it may impact COVID-19 vaccine with a younger population of 5 to 11?
Yeah, I think that's something that's very important. And I think before I answer the question about myocarditis, I'm glad that Katharine mentioned that most of these children with MIS-C or MIS-C need to be picked up early. And I think one of the things that we preach to our physicians in our practice, our staff, as well as many of our parents is, if you think something is going on, please keep us in the loop. And this all starts in the medical home. We know that myocarditis or heart inflammation is very rare. And we know that we can see it with certain viruses. And we know that we can sometimes even see it as a result potentially of a vaccine. In many studies that have come out after the initiation of the COVID-19 vaccine to elders or seniors to the over 18 age group, we know that males seem to have had a predominance in the number of infections. However, we know that myocarditis happens traditionally, especially in the summer, because many summer viruses are linked to this inflammation of the heart muscle. What we also know is that children that contract COVID seem to be at a little bit higher risk for more severe myocarditis and the syndrome that follows it. This heart pain, this tightening in their chest, the need to be observed sometimes very carefully. But one of the best things that we have seen with myocarditis is these children, these adolescents, these young males have improved and have gotten back into a more normal state of life. No kids have died from it. And we know that most of the patients that have contracted myocarditis, either as a side effect or an adverse reaction to the vaccine, or even to just the natural illness, have all recovered, usually within about a month. So if you look at these patients 2 months down the line, you would have no indication except their memory of having been in the hospital being observed and being watched by the excellent critical care physicians that we have in northern New Jersey and throughout the state and throughout the country.
And if I might just fill something in, I've taken care of quite a few of these patients. And the nice thing is the treatment that they need is really just ibuprofen. So although we're watching them, we're seeing their function go back, parents are really comfortable with the treatment that we've had. And in most cases, I would say in a majority, it's really just some ibuprofen and watching. So to give parents a little bit of peace of mind that the treatments we're needing are not, out of control.
Correct. I would agree with that. You know, this is an inflamed disease, and we know that inflammation typically is calmed by just an anti-inflammatory medication like ibuprofen.
Okay. And is it correct that the risk of myocarditis following actual infection with COVID-19 is higher than it would be after vaccination?
Absolutely. That's been proven time and time again. So you have a higher risk of getting myocarditis just from having a virus attack your heart than you do have it following the vaccine. Oh, there's Dr. Clouser.
We can see you now, Dr. Clouser.
I switched computers, so I'm going to turn off the other one so I'm not echoing.
Okay.
So yes, and I think what we also have seen is that individuals that contract myocarditis following the vaccine are not nearly as ill as individuals that contract myocarditis as an illness that's apart from the vaccine. It also seems to appear a little bit more frequently after the second dose than it did after the first dose, almost as if the body is responding in some kind of inflamed way.
Okay. And is there any concern that parents need to have following vaccination for COVID-19 about children returning to physical activity or sports? Any concerns about that? Dr. Clouser.
As long as the student or the athlete is not having chest pain, not having shortness of breath, there's no real concerns. I suggest that most parents give them about 48 hours in between their vaccine and kind of big activity to make sure that there aren't any, kind of big reactions. The American Academy of Pediatrics actually recommends that with any fever, regardless of the cause, that people are not doing sports for this risk to begin with, because fever itself is indicating some illness. And if we put stress on the heart by running, by doing some aerobic activity, that you can, have an increased risk for myocarditis in anything. So post-vaccine, I say don't plan for 48 hours to kind of do anything extraneous. But after that, as long as the child is asymptomatic, they can go back to their activity.
I'd like to add something to that. When this was presented last Tuesday to the ACIP, which is the group from the CDC, and then got Dr. Walensky's stamp of approval to say this is something we need to start, and many practices in northern New Jersey were doing this by the end of the week, they looked at side effects and adverse effects that come with this. And when medications, immunizations are tested and put out there in real trials. Anything that happens in a time frame is reported. So while there were no deaths with the vaccine in the group 5 to 11 following immunization, they did see a child that swallowed a penny, and that got reported as an adverse effect. There were 3 children that had broken bones. That got reported as an adverse effect. But again, we know that the biggest thing was there were no allergic reactions, and that was a concern that we had initially with the first rollout for adults, and we know there were no deaths. So we were able to manufacture in a timely fashion a vaccine that could protect an at-risk age group 5 to 11 without any significant side effects besides a lump on the arm or a little bit of tenderness or maybe a low-grade fever.
And I work at Hackensack Hospital, and we have not admitted a child with myocarditis post their vaccine since July. Not of any age. And so I think that that's a good sign that although we did see this initial spike, it was not severe, and we haven't had one in a long time. So I think parents can feel comfortable that we've vaccinated a lot of children 12 to 16, and they are not seeing the big side effects, and so kind of extrapolating out. That was also part of the reason why the trial took so long in 5 to 11, because they didn't have enough side effects. They were looking for myocarditis and they couldn't find it. So they kept enrolling more people to try to find it, and they couldn't. And so I think that that's another thing to kind of know, that they were looking for it, and since they couldn't find it, they did feel like it was safe.
That was one of the things that the FDA had asked for, because as you mentioned, the initial study, the study group was kind of small and they wanted a bigger enrollment. So they added another 1,500. This was a little bit different when they were doing studies with the adults, when they had people knocking at the door saying, give me the shot, vaccinate me, help me. And, you know, they had literally, I think, about 150,000 people that wanted to be enrolled. But many of us have friends and colleagues who enrolled their children. A couple of the doctors in my practice have enrolled their children even down now in the younger age group with the studies that are forthcoming, and hopefully we'll see by the end of this year.
Thank you. So Dr. Bienstock, we're talking about this rare side effect for COVID-19 vaccination. What could a parent expect as more common side effects for a 5 to 11-year-old getting vaccinated for COVID? What should they expect as common side effects?
I think that pretty much this is what we expect with almost all injections, whether it's the vaccine for COVID-19, or as you mentioned before, a measles vaccine, or any of the inoculations that we give to our children to keep them safe. We talk about fever, we talk about fatigue, we talk about headaches, chills, potentially diarrhea, maybe muscle and joint pains. However, with COVID, it doesn't seem to affect them on their first dose. In the studies that came out, and again, we'll see this in another 2 weeks when we give our initial patients 5 to 11 their second dose, they seem to follow the second dose, almost as if it's a memory response. Hey, you gave me this 1 week, and now 3 weeks later, I'm getting another one. But again, most of these children, like most adults, you know, maybe they were down for a day, a little tired, a little fatigued. Some parents will just blame that on overactiveness and being too aggressive, playing soccer or doing their dance or whatever they're doing. But again, when we looked at the serious adverse effects, like I mentioned, anything gets reported. And there's a group that follows this nationally, and people can even enroll on an app to keep track of their illnesses and how severe the side effects can be for their age group.
Thank you. So, and I see questions coming into the questions box from participants. Thank you. You can keep them coming, and we'll start to address participant questions in a few minutes. I do want to ask Dr. Clouser, we've talked about, you know, the vaccine is available for children 5 and up, really everyone 5 and up now in New Jersey. Tell us, what has been your experience in treating pediatric patients with COVID in the hospital? Why should parents want to get their children vaccinated for COVID to protect them from this?
So within the hospital, we initially really didn't have children who were being infected. So last March and April, I was actually taking care of 25-year-olds. I was taking care of 30-year-olds who were sick. And that was a great thing because it meant that our children were spared. But the reason our children were spared is that they were not at school, they were not at dance, they were not at soccer, and they weren't the ones going to the grocery store, right? They were staying home and really sheltered. As things have opened up and gone back to normal, and Dr. Bienstock really kind of spoke about the fact that we want them in school. They have got to go back to school. It's really important for their development and for you as parents, for your development as well. We know it's really hard to be a lawyer and a teacher and a soccer coach and everything else that you've had to be over the last year. So when they're back and they're being exposed to more things, more children will get infected. Within the last 5 months, we've had a 5-fold increase in hospitalizations in children. So what we were really seeing, it's been 5 times more. And kids are getting the same symptoms that adults were. I have people on the floor right now who are requiring oxygen, who can't eat or drink and are requiring IV fluids. So although they are doing really well and we've had very minimal deaths, I think that's fantastic. Even 1 death for me of a vaccine preventable illness is too many. And I think that there's no parent who's going to tell me that there's an acceptable number of children to die from a vaccine preventable illness. On top of that, being in the hospital for 3 days, needing oxygen, needing IV fluids, needing IV steroids, needing other medications to treat a virus is really inconvenient for the entire family. And I don't say that lightly. It's really kind of disruptive to their school. It's disruptive to the parents' jobs. Then you're quarantining for another 2 weeks. And so it really just kind of impacts life more than just life or death. And I always say that there's something in between living and dying and having side effects and being sick. The other thing is kids are having lung infections that last much longer than what we're typically used to. So although they're leaving the hospital, some have left the hospital needing oxygen. Some have left the hospital needing a new inhaler that they didn't need before. Some have left the hospital where they were the star of their soccer team and they can no longer run that mile anymore. And I think that it is impacting quality of life and what they're able to keep up with. I've also seen people who really can't recover and get back to school. So maybe they had straight A's last before COVID, and now they're struggling to get C's and D's. So although they're surviving, and I think that that's really fantastic, and we've done a great job in managing it, it's not just about that. And there are kids who do get acutely ill. We've had kids who've needed to be on a breathing tube. We've had kids who have needed medication to support their heart and their blood pressure. And I've had kids who have spent 4 weeks in the hospital with COVID-19. So it does affect kids, not at the numbers it's affecting adults, but it does affect kids. And if you can give your child a vaccine that's going to prevent them from needing the hospital, I think that's a great thing.
Absolutely. So COVID-19 is a vaccine preventable disease at this point for 5 and above. So we need to take advantage of that. There's a question from participants that relates to what you were saying, Dr. Clouser. So I'm going to ask it now. An 8-year-old patient who has had MIS-C in June of 2020 is complaining of significant problems with memory and concentration. Is there anything to offer him now specific to MIS-C?
So there's nothing, it's not specific to MIS-C, but we are seeing a phenomenon called long COVID or post-acute sequelae of COVID. And those, that's a symptom that we saw in adults starting last fall, and really kind of in the springtime started to notice that it was also affecting children. So this 8-year-old child is not alone. I have a center here at Hackensack where we're seeing post-COVID syndrome patients. I work with the general pediatricians who have been managing these children in their offices for a long time. And what we look at is neuropsych testing, which is a specific look at what happens with their IQ. I also work with my rheumatologists, physical therapists, talk therapists, and the neurologists as well to kind of multidisciplinarily address this. We don't have a treatment for what we're kind of looking at as long COVID syndrome, and it can be related to the MIS-C. It can also be related to that COVID infection that the child had before. Even asymptomatic, some people are then having long COVID syndrome. And I think that it's important to note that there are a couple centers around that are kind of addressing this and looking at, are there treatments that we can give? Sometimes maybe they need some more steroids. Sometimes it's really about physical therapy. Sometimes they need some new tutoring. There's lots of different mechanisms that we can work with children to do. And there are studies that are looking at which children may be at risk and what treatments may be helping, and those are emerging now.
Thank you. Dr. Bienstock, how do we know that getting a child vaccinated with COVID-19 vaccine is safe, especially that 5 to 11 group? Is this, too new to give to our children? How do we know it's safe and that there's no long-term side effects? So, for example, something that you see circulating online a lot is this idea about infertility associated with COVID-19 vaccine. There is no association there, but it's online, so people see it. And so can you address that?
Yeah, I think long-term effects, especially with infertility, because that seems to be one of the big things that we're hearing. Could it be an effect of the illness, or is this an effect of the vaccine? And we know the vaccine doesn't do anything. We know mRNA vaccines do not change the DNA. There have been thousands of women that have become pregnant following COVID. Some have even had COVID during the pregnancy. We were involved with 2 of the first babies born at Hackensack back in March of 2020 with 2 moms that were pretty sick. Fortunately, they were able to recover, but there are countless stories of people that have contracted COVID without being vaccinated and have lost their pregnancy. So the vaccine we know is safe. The concern, I think, came from one person who may have had no knowledge. Obviously, I shouldn't say obviously, but probably did not wear a stethoscope. May have just been somebody surfing the internet. But we really know that the vaccine is protective and will be effective. And again, if you're contracting COVID and you're so sick, you may not be able to hold on to that pregnancy. One of the things that has been brought to our attention in the office, though, now is a new thing with the potential change in the menstrual cycle of some of these teenage girls. And what we have seen is this is another inflammatory response, that if somebody does contract COVID, it may throw their cycle off the same way a febrile illness can, or the flu. And that seems to come back over time. I think we're too new in this game to know for sure, but what we have seen is there's no effect on the pregnancy, and that's why the American College of Obstetrics and Gynecology has supported vaccination for women that are pregnant, will become pregnant, or while they're nursing. Pediatricians are very happy when the mother agrees to this. And we also know that this does not have any effect on the sperm of a partner that somebody may have, either through artificial means or through natural means of becoming pregnant.
I think part of the, kind of, and I'll call it a rumor that started, was because, the spike protein and shares DNA with the placenta. And the amount that it shares, we actually as humans share more with a trout than we do with this, that these 2 proteins are in common. And I use a trout in particular because I don't know anyone who's going to go try to hold their breath and swim underwater. So we're basing a lot off of things that are associations, but not as much causation as we think they are. We share DNA with a lot of things that we don't kind of then base our whole idea off of. And it's been looked at now, and I also think about the fact that sheer numbers of people who have been vaccinated at this point is really high. And so if there were side effects or infertility or miscarriages that were going to emerge, we have never had better numbers of a new kind of thing, and worldwide. And I think that that's something also to know, that worldwide we're not seeing an increase in miscarriages, and we're not seeing an increase in infertility this year compared to last. And I think that you can just know with the share, hundreds of millions of people have been vaccinated just in the United States. And so you can kind of base that data off of, knowing what other people are doing.
Yeah, I think what Katharine mentioned is something that we need to listen to. Here we have a vaccine that was rolled out in front of millions of people throughout the world with tremendous sense of urgency to put a damper on such a terrible illness with hundreds of thousands of people dying. But we've been able to follow this looking through a magnifying glass where everything is looked at so carefully. Not that the FDA doesn't normally do its job, and not that the CDC doesn't license things and give approval to things that are also important. But I think we have so much data now on such a dreadful illness and something that's helping to stop this better than any of the medications that are out there that are being, brought to the forefront with more studies. We've watched this, we've seen hundreds of millions of people vaccinated worldwide. And I think for anybody to think we haven't done a good job internationally as a community, they're not looking at the big picture.
Right. I've always felt very confident in recommending that parents vaccinate their children with our routine immunizations because the safety data is so strong. And yet when we look at COVID-19 vaccination safety data, it's being monitored even more heavily than just our routine vaccines. So to me, that's makes you feel even better about COVID-19 vaccine, that it's being looked at so closely.
And a lot of the vaccines that we routinely give aren't, because I hear a lot about, well, why vaccinate something that's not going to kill you? A lot of the vaccines we give are for illnesses that don't kill you. Varicella can be very severe, but for most people, if you remember having chickenpox, it didn't kill you. But it was really inconvenient and really terrible for children. And I think that a lot of the vaccines that we give don't necessarily kill people. Some do. There are many that we give that are, deathly illnesses, but not all of them. And, we're doing it because it prevents morbidity, which is another word that we use. That just means being in the hospital is terrible. Having a kid at home sick for 2 weeks is terrible. And if we can prevent that, we're going to.
Right. And we do see with COVID-19 in children that although comorbidities increase their risk for hospitalization and severe outcome, there are healthy children that have, landed in the hospital with COVID-19 with no underlying condition. So it's really hard to predict which child will, have severe outcomes from COVID-19. The same with adults. So Dr. Bienstock, a question that came in from our audience is, will the COVID-19 vaccine for children be like a flu vaccine and be required on an annual basis?
I don't think anybody knows that answer for sure. I was surprised that we ended up with boosters as quickly as we did. I had my first shot back on December 20th. I had my second vaccine on January 6th, the closest that I could get it, which was 17 days. And then back in September, the recommendation was for healthcare providers, people with underlying medical conditions, seniors, was to get a booster to kind of bring that response up, knowing that maybe it was even protected against some of the variants that we were seeing. And at that point, the Delta variant was very big. Do we know for sure? I don't think so. Would I like to say if this is going to help us, and going back to what we said in the very beginning, get back to a more normal way of life with children running around and playing and enjoying holidays and not having to worry about some people, as you said, wiping down their groceries. And I mean, I think if anything that we can do, we should do. And if it means that this has to be something that we get yearly, maybe. I just don't think we know 100% for sure. And I think this is going to be a wait and see. I think every time we're going to open up a new window, we may see things that we like, we may see things that we don't like. I just think people need to remember where we were back in March, April, and May of last year, when the lead story every day in the newspaper, on the news, on the radio was another death, more deaths. This was tragic. So I don't think we know. I wish I had a better answer. I wish I could look into the future and say yes or no, but at this point, I don't think it matters. If it is, it is. If it isn't, great, one less shot for us to have to give to children.
Thank you. And Dr. Clouser, kind of going along with that, so if we have a pretty high vaccination rate for COVID-19 in New Jersey, how do viruses operate? Do they seek out unvaccinated to infect? So if we're going, down the line of the children that are not eligible for vaccination yet or have just received eligibility. Is that who the virus is going to turn to now? How does this virus work?
So that's part of the reason why we think we've seen such an increase in pediatric hospitalizations over the last 6 months, because adults are doing a great job of getting vaccinated. That being said, the more people that we vaccinate within the community, and so although we had, over 70% of adults in New Jersey vaccinated by June, which was fantastic, and I think we've done a wonderful job, and I really commend everybody who stepped up and got their vaccine. I also, like Dr. Bienstock, was like signing up the day I could. I really was one of the first 50 people in New Jersey to get my vaccine. I wanted it. I saw how terrible it was. But I think a lot of, people in the public really kind of took a risk and said, I'm going to do it. But that still left children, and children make up 20% of the population. And so I think that as we continue to increase that percentage, it will become less prevalent. But yes, it will seek out the unvaccinated. It's also going to seek out people who have immunocompromise or who maybe didn't respond as well as somebody else to the vaccine. And some people we know, right, if you've got an immunocompromised state, you have a disease that makes you more at risk for infection than somebody else, or if you're on chemotherapy, you're going to be at higher risk. I do think that this is probably, and most I think experts are thinking this is probably going to be something that we call an endemic virus, which means it lives with us and we figure out how to treat it. And so in similar ways to where the flu can cause problems in some populations and not in others, I think this is going to be very similar to that. But vaccine is the way that we're going to get to that point, from going to a pandemic, an epidemic virus causing a problem in everybody, to an endemic virus where we just live with it. And, it causes a cold here or there, but it's not causing the extreme problems that we've seen over the last 2 years.
And we need to use vaccination in order to get there.
Correct. Yes. Yes.
So, go ahead, Dr.
Bean. On our hands and forget about a mask and washing our hands and, being careful about who you're with. I just read an article earlier today in The Atlantic about somebody that was a reporter, went to a wedding and brought back COVID, and how this fragmented his family, his 2 children, 5 and 8, and made it so difficult to live a almost normal life for those weeks following a trip to a wedding for a friend. So yes, we were vaccinated. Yes, there were still 11 people at that wedding that got COVID. And again, the vaccine helps, but there are still other things that we need to remember, like we would with any kind of upper respiratory. You're not going to cough on your friend. You're not going to shake hands with somebody if you just sneezed in there.
I think that's the big thing, is if you can take reasonable precautions, it's going to help a lot. So this is a multi-tiered approach. The vaccine is a great way to really reduce the infection profile, but there are other things that you can continue to do. And one of those is, if you are sick, stay home. I hope that that's what we learned from 2020. I think we were approaching a place where people felt like they needed to go to work or school despite the fact that they had a fever of 102, and we saw it all the time where someone would go. And to be honest, you don't want anyone's anything. If they have the flu, you don't want it. If they have a cold, you don't want it. And so I think that I'm hopeful that people start to realize it's okay to stay home from work. It's okay to have a day off of school. It's okay to not cough on all of your friends and get on that airplane. I think that it's okay. And so if you're feeling ill, taking that kind of common sense precaution that we lost that as common sense. And I'm just as guilty as anyone else. I will tell you, I have worked ill, put a mask on, and had to sit through, whatever it may be. And I'm hopeful that people learn that that's not the correct approach.
Thank you. So we have about 10 minutes left in the program, and we have a lot of questions. So let's go ahead and start pivoting to those, and I'm sure we'll have some more come in. So Dr. Bienstock, would you recommend spacing the first and second dose for more than 3 weeks for children 5 to 11 years? Some studies have shown higher immunity response and lower side effects if the second dose was done 6 to 8 weeks after the first dose.
I think some of those studies are not 100% in what we need to do. And the way the vaccine was licensed was with the knowledge that the vaccine should probably be somewhere around 3 weeks from vaccine 1 to 2. Again, I think we're learning as we go forward. As we said before, the sample size for the 5 to 11 was not as robust, was not as many individuals. So we're still going to learn. But again, the side effects that we're worried about are local effects. A little bit of fever, a little bit of arm soreness, maybe some diarrhea, maybe some fatigue, maybe some joint stiffness, things that kids get all the time. So I would stick with the science here. And the ACIP, when they met last Tuesday, this was one of the things that they talked about. That's open for the common domain for people to just log on and go back and watch the 8 hours of talking that they did on Tuesday in preparation for, the approval of the vaccine for the 5 to 11 age group.
Thank you. And right now, what is the recommended dosing and spacing?
Right now, the recommended dosing is 0.1 micrograms, which is 1/3 the dose of what adults got or continue to get. And the feeling was that with this dose being given around 3 weeks later, there's always a short and a long. As I said, I got mine 17 days, which was less than 3 weeks. I don't know when Katharine got hers. But the whole idea is a smaller amount seem to do the job. The individual that's a very big 5-year-old and a very small 11-year-old, this is not a vaccine that's dosed by weight. Most medications that are used in pediatrics is all dosed by weight. This is an age-related vaccine, the same way that we give age-related medications, say for asthma. There's an asthma medication that's dosed by age, not by weight. So there are some big 5, 6, 7-year-olds, and there are some small 11-year-olds. The bigger concern happens with what happens when you're giving that dose to a child that's 11 years, 11 and a half months old, knowing that in 3 weeks they're going to be 12 years. Do they get a step up or do they continue on the 0.1? And the recommendation is you can give whichever one you want. They can get both 0.1s, which is 1/3 of the dose that hopefully everybody on this webinar received already, or they can go ahead and get the increased dose. But the point is not to wait. That 11-year-old, 11 and a half month old that's going to turn 12 on December 1st should get their first dose this afternoon.
It's all about their immune system. So it's not their weight, it's because of how the immune system works. And, 12 is roughly the time of puberty, so that may have something to do with it. But you may find that in 3 years, we say that 12-year-old should have gotten less of the dose. We may find that as studies continue. And I want to stress that I don't want parents to worry if their 12-year-old gets the 0.3 instead of the 0.1, that they did something wrong. The best thing to do is to get the dose as fast as you can. And so even if we find out in 3 years that maybe we all only needed the smaller dose, or that we all needed the bigger dose, and those may be things that we find out in 3 years, 5 years. Along with Dr. Bienstock, neither of us have figured out the crystal ball yet. When we do, we'll let you know. But I think that the important thing, as he said, is just get it done. We're heading into a holiday season. I would love it if when I come back from the holidays in the winter that I don't have a rush of COVID patients like I did last year. That would make me really happy. I think that Dr. Bienstock would love a break, because what I'm seeing in the hospital, the pediatricians in the community are seeing 10-fold, 15-fold, 20-fold. There are tents in parking lots, there are office visits in cars. I think if we can prevent that from happening by just getting the shot, it'll really help.
Absolutely. So for one of the questions is very specific. So for 2 boys ages 5 and 9, so within this age group, they have a history of febrile and epileptic seizures. Would those be considered pre-existing conditions for not getting vaccinated, or recommended that they would not receive it?
I'll say they should receive it.
I agree. Yes, they're not pre-existing. Yep.
They're not at higher risk. A child that suffers from febrile seizures, we know how to keep their temperature down. So a child, say, having a side effect or an adverse effect to the vaccine where their fever is starting to creep up, those parents hopefully were counseled by their pediatrician on the best ways to maintain lower fever so they don't have a quick rise or a quick fall in their fever. A child with epilepsy, whether it's caused by something that we know or something we don't know. Remember, there's a lot of reasons for epilepsy. It could have been from a prior illness, a prior injury, but they're not at higher risk than the next person walking down the street. And they should both be vaccinated and vaccinated again this afternoon.
There are certain vaccines that have been associated with febrile seizures in the past, and we do know those. This is not one of them. So somebody is not at an increased risk. And epilepsy, believe it or not, actually results in more severe COVID. And they can have some of the neuro side effects that we have seen, which includes inflammation in the brain, and they're at increased risk for that. So having the natural infection is actually a higher risk than getting the vaccine. So I agree with Dr. Bienstock, make the appointment today.
Okay. Thank you. How would you respond to a report that says that long-term side effects in children are unknown because it's not been tested in a large population and that they should wait longer to vaccinate their children?
There are not long-term side effects of any vaccine. And that's one thing that I think we know. We have been vaccinating against the measles, for example. Well, sorry, I won't say measles, for polio since the 50s, right? We know that. And there are not longer-term side effects of the polio vaccines, even when we were bad at them. And that's one thing to remember, is that in the 50s, we weren't good at making vaccines. They had very high inoculation rates, they had very high antigen rates, and we're better at using the smallest amount of antigen as possible. So these vaccines, the content of the vaccine is protein, fat, and salt water. There's no preservatives, no metals, nothing else there. And so your body can handle protein, fat, and salt water very, very well. So we can extrapolate that because most side effects for vaccines happen within the first 3 months, we actually have long-term data. We know 3 months later what's going on with these children, and they're great. They don't have COVID. They're back at school. They're doing really, really well. So I think that the reports are kind of yielding in that direction, that we won't have long-term side effects. We know there are long-term side effects to having COVID. I am treating children who have effects a year later from their first infection who are not back to normal. So for me, taking that risk that there could be a long-term side effect of a vaccine versus getting the infection where we know there are long-term side effects, it seems like a no-brainer to me that you want to try to avoid getting the infection.
I agree.
Okay. Thank you. I'll ask one more question from the audience, and then we'll give each of you a chance for kind of final comments. So once kids are vaccinated, will they be able to go to school without wearing masks?
Well, I think we hit on that a little while ago, that while vaccinations is the first step to getting children and adults into a more normal life. Again, with the holidays coming, I don't want to harp on turkey too much. But again, I think the big thing is that's only one step. And, you know, we shouldn't just let our guard down, because even somebody that's vaccinated could potentially contract COVID. Even somebody that's vaccinated for COVID could contract influenza. That's why children need to be vaccinated. Children need to be vaccinated on time, as do we. We want everybody to be vaccinated for COVID, as well as the influenza, as well as other preventable diseases. But as we talked, a mask is important. Staying home when you're sick, being a good citizen, being a good neighbor, being a good person is what goes together. And I think if we remember that, I think we can all look back maybe 3 years, maybe 5 years, and say, hey, we did a great job.
As the virus becomes more endemic, I am hopeful that we will be able to go to school without masks. In the same way that right now there are set scenarios where you may go without a mask, right? I see friends who I know are vaccinated who are low risk, and I don't wear a mask. You know, there have been times where I've gone to the grocery store without a mask if I know I'm going quickly and, you know, taking proper precautions. And I think that at some point we will get to that if we vaccinate enough children. The CDC has been really following this closely and has mentioned that adults who are vaccinated don't necessarily have to wear a mask if the infection rate is low. And so if we can get our infection rate low, so there are places where it is low, right? And there are places where it's high, and the recommendation is going to shift depending on where you are. And I think that that's going to be the same in schools, that once enough children get vaccinated, the CDC is going to look at it and say, if your school has a low rate, maybe people will be able to remove their mask. But I think it's going to be county by county, school by school dependent. And I also think it's going to be seasonal dependent. You know, Dr. Bienstock talked about the flu and other illnesses. If your school is having a spike, the masks may come back on, and then maybe in the summertime you'll be able to remove them again. We'll just have to see. But I am hopeful that with enough people vaccinated that we'll be able to kind of return to some of these more normal things.
Yeah, and I will say that children seem to have taken the masks very well. I have a 3-year-old and she loves her mask. So
yeah. I was going to say, most kids are not mad about it. It's their parents who are worried, but the kids will wear them all the time and remind their parents, I find. When I walk into a room and I'm seeing a kid, the kid's got the mask on and says, Mom, you don't have yours on. So I think you're right. They're doing fine.
Yeah. So any final comments, Dr. Bienstock?
Yeah, I think, you know, what we have learned and what the CDC data has shown us is there have been 2 million cases. There have been almost 10,000 hospitalizations in this 5 to 12 age group. We're almost at 150 deaths. One death was too many. Fortunately, our hospitalists, our intensivists are taking care of these children. But vaccinating children plays a role in transmission, and vaccinating will allow these children to be back in school so they can have in-person learning. And I think we need to be careful with the long-term sequelae, you know, these long haulers, the multisystem inflammatory syndrome for children. We need to do a good job. We need to get parents to listen to the science and to show them that we really care about their children. We're there for them today, we'll be there for them tomorrow. We're always there to help them to get through things.
Very important message, Dr. Bienstock. Dr. Clouser, any closing comments?
I think what I like to tell people is that where we are now is heads and shoulders where we were 18 months ago. Your pediatricians know how to deal with COVID better than we did before, both in the hospital and out of the hospital. And so if you're concerned, don't worry about the stigma. I've heard a lot about, like, I don't want to be the one who got COVID. It's okay. We will handle it. We are exactly what Dr. Bienstock said. We're there for you. And I also like to remind people that your kids pick up on your attitude. So if you're really anxious about it, your kid's going to be really anxious about it. If you have a problem with masks and washing your hands and staying away from people, your kids are also going to have a problem. But if we kind of approach it as we're doing this to be a good neighbor, we're doing this to prevent someone else from getting sick, they're going to learn a whole lot of lessons from you. And when there are questions, go talk to your pediatrician. There's a reason why you trust them with everything else. Trust them with this as well. I promise there's no judgment if you come to me and say, I watched this video on YouTube. You know, I'll be able to break it down for you. And I'd rather answer your questions than have you worry about something that you read online.
Absolutely. That's great advice. Thank you so much, Dr. Clouser and Dr. Bienstock. I think this has been a really informative hour. And I appreciate the questions from our audience members. And I think the message today was very clear that, you know, COVID-19 vaccine is approved for ages 5 and up. And don't wait. It's here and it's available in New Jersey. It's important and you need to make an appointment. And if you have questions, reach out to your pediatrician and they'll be happy to answer questions. So that's all we have time for today. I'd like to also thank Karim Amadio, who is handling technical back end of the program today. And thank you all to our audience who has joined us today. A reminder that you will receive a link to a post-program evaluation. Your feedback's important, so please take the time to complete that survey link. And certificates of completion will be sent via email that you provide on the evaluation within 1 week. A calendar of the partnership's upcoming virtual programs can be found at pmch.org under the Professional Education tab. And please join us for a webinar on December 8th on COVID and the vaccine in pregnancy and breastfeeding. We also offer on-demand recordings of many of our programs, which are listed on the website. Thank you, and we hope you can join us again for an upcoming educational event. Thank you.